So let's take a look at the first building block, the health workforce. When we talk about the health workforce, we have to first ask ourselves, who do we consider as part of this workforce? Now, each country can decide, but there are also lists that the WHO has created that have got the common categories that you will find familiar, such as doctors and nurses and physiotherapists. A common reality in health workforce is that there's a shortage of health professionals, and very few countries have got a surplus. Now, in response, countries have gone forward and created new categories of health workers. The advantage here is obvious. Training is shorter, and once qualified, these workers are often far less mobile than doctors and nurses. A second response that countries have started to implement is task sharing. Task sharing is when a change is made in the professional scope of practice. And here we can use an example called NIMART, Nurse-Initiated Management of Antiretroviral Treatment. In this scenario, doctors used to always do all the prescribing and supporting of patients who are on antiretroviral treatment. But due to the shortage of doctors, the scope of practice of nurses has now changed, and they may now prescribe and support patients on this kind of therapy. The concept of skills mix. Skills mix refers to the mix of posts in an establishment, such as a primary healthcare clinic. Because healthcare is labor intensive and that the cost of labor accounts for a high proportion of total costs, often 75% or more, managers and health professionals have to try to identify the most effective mix of staff that they can achieve within their available resources. So a typical team that you might see might only have one doctor, several nurses, and several auxiliary workers or mid-level workers. We will discuss distribution, production, retention, and supplementation in a moment. In order to understand the situation of the health workforce, let's use some pictures. On the screen in front of you, you can see the atlas of the world as you would expect to see it in a book. In this version, countries and continents have either been expanded or contracted to show the proportion of doctors and nurses working. It is easy in this picture to see how Africa has contracted, for example. It is almost non-existent, when if you look to your extreme right, there's a big purple blob, and that is Japan, which is much bigger in the picture than it is in the geographic map. In other words, they have more people per 100,000 than we would, for example, in Africa and South America, which is also very contracted. In this picture, you can see that sub-Saharan Africa in particular has expanded enormously, and this is a reflection of the HIV and malaria prevalence. So it's not difficult to compare the two. In the previous slide, you saw Africa that was almost non-existent with regard to the number of doctors and nurses working, but in this one you can see the burden of disease, and it's very clear that there is a disconnect between the two. Already you now know that doctors, nurses, and other healthcare professionals are not distributed fairly across the disease burden. So let's have a look at another map. On this map, it is easy to see the countries that are shaded in the darkest. These countries have the lowest ratio of doctors, nurses, and midwives per 10 million population. The question is raised about those countries that are shaded in the lightest and who therefore have the most favorable ratio. Are they producing and retaining enough of these categories of health professionals? Or are they supplementing their shortfall from other countries, who then in turn might experience their own shortfall? Not only are there problems with the distribution of healthcare professionals over countries, there are also problems with the distribution of healthcare professionals within a country. So, for example, on your screen, you can see that if we only look at country-level data, we will not notice that there are certain provinces, and this is a South African example, that have a much more favorable concentration of healthcare workers. Typically, these are urban areas, and rural areas usually have the lowest healthcare provided to population ratio. What is striking, and that is in particular in the free market system, is that there's a maldistribution of healthcare professionals between the public and the private sectors, between urban and rural areas, and between the formal urban and informal peri-urban areas, as well as between tertiary and primary levels of care. So what can countries do to overcome the shortfall? Countries can either produce more, retain more, supplement from other countries or other cadres, or to use task sharing, as we previously discussed, which is using other categories to do tasks. The problem is if we want to produce more, it is often difficult to keep up with population growth, as professionals also immigrate, retire, die, or decide to work in other sectors. Retaining healthcare professionals is difficult because doctors and nurses, for example, are both mobile and highly sought after as we have a global shortage. Here you can see that already in 2006, more than 1/3 of all South African doctors were working outside the country. Another way to overcome a shortage is to supplement from other countries. Now, South Africa has several countries whose doctors we use. Most of them are short-term, so for example, the English doctors who come might only come for a few years. But South Africa has also had a country-to-country agreement to employ doctors from Cuba, and we could do that because Cuba is one of the few countries who overproduce doctors. Let's turn our attention to the next WHO building block, health information systems. We need 3 levels of data in order to manage a health system. So let's look at the first 2. At the first level, individual level data is collected about the patient's profile, healthcare needs and treatment, and we can use this kind of information or data for clinical decision making. An example of such a source would be, for example, individual healthcare records. At the second level, health facility level data makes it possible for healthcare managers to determine resource needs, guide purchasing decisions for drugs, equipment and supplies, and develop community outreach. An example of community outreach might be, for example, that a clinic manager suspects that patients with TB are not presenting at the clinic. In other words, the numbers are lower than expected for her area. She can then either do household testing or run an awareness campaign. An example of health facility level data is, for example, drug procurement records. The last level of data is population level data. Population level data are essential for public health decision making and generates information not only about those who use the services, but also, crucially, about those who do not. One way to collect this kind of data is with household surveys, and we typically do this as part of a census. Public health surveillance brings together information from facilities and communities with a main focus on defining problems and providing a timely basis for action. For example, in an outbreak situation, we would use public health surveillance in order to determine if it is an outbreak. Let's look at the next WHO building block, access to essential medicines. According to the WHO Framework for Health Systems, a well-functioning health system ensures equitable access to essential medical products, vaccines, and technologies of assured quality, safety, efficacy, and cost-effectiveness, and their scientifically sound and cost-effective use. This is not easy to achieve. In order to do this, the following are needed. Firstly, national policies, standards, guidelines, and regulations that support this. Secondly, information on prices, the status of international trade agreements, and the capacity to both set and negotiate prices. Thirdly, reliable manufacturing practices when they exist in-country, and quality assessment of priority products. Fourthly, procurement, supply, storage, and distribution systems that minimize leakage and other waste. And finally, support for rational use of medicines, commodities, and equipment through guidelines and strategies to assure adherence, reduce resistance, maximize patient safety and training. Monitoring access to essential medicine is closely intertwined with at least 2 other building blocks, that of service delivery and governance. Don't forget, the chief reasons why patients go to another primary health clinic rather than the one that they are allocated to is stock out of medicine. Let's look at the second last building block, that of financing. While the goals of health systems financing can be expressed in various ways, there is a general consensus that it should seek not only to raise sufficient funds for health, but should do so in a way that allows people to use the needed services without the risk of severe financial hardship, often called financial catastrophe. We do this by raising sufficient funds and providing financial risk protection to the population. These objectives can be achieved more easily if the available funds are used efficiently, highlighting the need for a third objective, that of efficiency in resource utilization. Let's once again use the familiar shape and size of the continents to demonstrate healthcare financing. This image is a reflection of public sector spending. Take a moment and find yourself on the map. You might, for example, be in Africa, which has almost disappeared. This image is a reflection of private sector spending. If you look at the map, it would appear that it is only South Africa, in Africa, that has substantive private sector spending on healthcare. There are three key terms you need to be able to use when talking about health sector financing: revenue collection, pooling, and purchasing. And we'll look at each of those in turn. So where do we find money to pay for healthcare? We can either use tax, or we can use compulsory contributions which we deduct from the salaries of the people who are working, or we can have a voluntary subscription to private insurance schemes. And in most cases, we also have something called co-payments, which is an out-of-pocket payment, which you might find in combination with any of the others. Let's look at the sources of funding per capita, in other words, per head. Here you can see the sources of financing, both public and private, per person, and we can also see who spends the most. That is the column on the extreme left of the screen. In this slide, you can see the top lighter shade is private funding, or private sources of funding, while the bottom darker shade is public sources of funding, which is in other words paid by taxpayers. It is easy to see that some countries, like the USA, on the extreme left, have approximately 50% public spending versus private spending, and the one right next to it, Norway, is mostly publicly funded. The United States of America is a free market system and spends approximately 3 times more per person than Australia, Canada, and the UK, without any measurable better health outcomes. As a matter of fact, life expectancy is lower. And the cost drivers in this system are things such as the system fragmentation, it's hospital-centric, and health insurance, which makes people far less price sensitive. In a health insurance environment, it's called the third-party payment model. Both the doctor and the patient are not aware of the full costs of providing services, and therefore can either oversupply or over-demand a service.